Hi, good afternoon, everyone. Welcome to our Chicago Asthma Consortium members and to our guests. If you could please mute your microphones and hide your videos. You won't need those for the presentation today. This is our Lunch and Learn series, which is 30-minute presentations on topics relevant to the treatment of asthma. And today, our topic is advancing health equity by removing race from PFT reference equations. So uh, yeah, I'm just by way of introduction, my name is Matt Seymour. I'm the executive director at Mobile Care Chicago, where we have 3 asthma and allergy clinics that travel around into different low-income areas and provide free medical care for people, primarily children. And I'm also the president of the Chicago Asthma Consortium. Um, and in the capacity of the Chicago Asthma Consortium, we advocate for policies that affect people with asthma. We also educate people about different factors that might affect the treatment of asthma. And then we collaborate. And that's what we're doing here, is to sort of bring people together on topics that are relevant to the treatment of asthma, and then make sure that people have a place where they can network with other folks who are in this field, and get the information that they need, especially when there's advances in asthma treatments. So our schedule today, I'll give a brief overview, which I'm doing, and then we'll have our speaker, Dr. Min Ju, and then we'll have a question and answer session at the end, and then we'll close promptly at 12:30. A little bit of housekeeping items. You can keep your video and audio off during the webinar. If you have any technical difficulties, you can chat Mary Eileen in the chat feature at the bottom, or you can email info@chicagoasthma.org. We welcome folks networking and communicating in the chat. Introduce yourself and say hello to everyone else. And as the presentation goes on, if you have any questions, feel free to put those in the chat, and I'll make sure to aggregate those and then bring those to Dr. Ju at the end, so that we can have your questions answered. And then at the end of this presentation, we'll also have an evaluation. That'll get sent out in the chat, and then it'll also be sent out to you via email. Your responses are really important. They help us to bring topics to Lunch and Learn sessions that are relevant to you, and make sure that we're just doing our best to present material in a way that's helpful. A little bit about the CAC, and I touched on this a little bit. Our mission is to improve the quality of life for people with asthma through advocacy, education, and collaboration. And really what we do is we bring together a lot of stakeholders who interface with people who have asthma, whether it's parents who have children who have asthma, people who have asthma, business leaders, government agencies, health professionals, people who are providing direct medical care, and bring them together so that we can all be on the same page on improving quality of life for people with asthma, and making sure that all of our sort of public institutions are helping people with asthma have the same access to resources as everyone else. And you can learn more about us at our website, chicagoasthma.org. And then you can also volunteer with the Chicago Asthma Consortium. We are a completely volunteer organization. These are all of our committees represented here. And we have volunteers who are helping us out in the work of each of these areas. So we have a community advisory board that researchers can access when they're structuring research projects. We have a community engagement committee, fundraising, membership, professional development, which is the committee putting on the Lunch and Learn today, and then a schools committee. You can join our board of directors if you like. We are accepting applications, and you can contact info@chicagoasthma.org for more information about that. And with that, that's the end of my introduction. So I'll send it over to Dr. Min Ju. We're very pleased and honored to have her here with us. And Dr. Ju, if you could give a brief introduction to yourself, and then we'll go into the presentation.
Great. I am going to go ahead and share. If everyone can see my slides. So people can see my slides, I'm hoping.
Yes.
Perfect, great. Thank you, Matt and the CAC for inviting me. My name is Min Ju. I am a professor of medicine at the University of Illinois, Chicago, Pulmonary and Critical Care Division. I am the co-chair of the DOM Inclusion Council at UIC as well. I'm also the medical director of the UI Pulmonary Function Lab, and I've actually had that role for probably more than a decade. I'm also the chief of pulmonary critical care and sleep at the Jesse Brown VA, and also the medical director of the PFT lab over there as well. And one thing I did not mention, I am recently a member of the Jesse Brown for Black Lives, which is a committee over at the university or at the Jesse Brown VA, really focused on working on removing race from clinical algorithms. And this is really where this project was led, moving forward to removing race from PFT. So today my talk is going to be about advancing health equity by removing race from PFT reference equations. To start, I think everyone agrees that race is a social construct. Humans share more than 99.9% of their DNA. Skin color correlates most strongly with UV light exposure and not biology. And because race is a social and not a biological construct, it makes no sense to say that race determines biological differences. The current practice of lung function, however, assumes that healthy Black patients have worse lung function compared to Caucasians. What I mean by that is lung function is reported as two values. One is an absolute value, meaning what the patient is actually able to produce as their own lung function. And that is often divided by what is expected for that individual. And what's presented as a percent of that expected. That expected value is derived from race-based reference equations historically that were developed using what's considered a healthy population. So they will sample individuals of various ages, heights, sex, and race. And then they would create reference equations based on race, accounting for age, height, and sex. So you would actually choose the race, it would choose a reference equation accounting for age, height, and sex, and it would pop out the expected value. But choosing the correct race-based reference equation in itself, not only is race a social construct, but choosing the race is also an issue, because again, it relies on the patient's self-identity, which is often based on a social construct, which I mentioned. But oftentimes, if you ask how they're choosing race, it's the person performing the test or the technicians and their best guess of someone's racial or ethnic background, which can lead to misclassification as well. The Global Lung Initiative is an organization that developed reference equations for spirometry, and this was published back in 2012. And the goal of the GLI was to establish improved international reference equations using a much larger cohort than what the vast majority of USA was using, which is called the Hankinson's equation, which is derived from the NHANES-3, and I'll talk a little bit more about that. It's currently recommended by our professional societies to use GLI if we have them available. And it was really touted as data that was collected from multiple countries where they were asked, give us spirometry data that you have that is of a healthy cohort. And they collected all of this data and then reran the analysis to develop these reference equations. And this actually included almost 32,000 males, more than 42,000 females, and had a broad age range of 2.5 to 95 years of age. But when we talk about what the reference groups or the racial groups that were identified when we use GLI, you see those on the left. We are asked to choose specific group names, either they are Caucasian, Black, Northeast Asian, or Southeast Asian. These are the racial categories. And then there's an other for people who don't seem to fit into any of those categories. And first, I want to comment on the total number of individuals included in each of those groups. And you see a huge disparity in the number of 57,000 Caucasian, you see that only 3,500 were Black. And in fact, I'll start from there. They were from the country region up, they were just African American, and I'll talk very much more about that. And then there's Northeast Asian and Southeast Asian, and these are the categories that we are supposed to identify people into if we use race-based equations. But what you see there is when the GLI group actually devised these equations, a lot of it was based on who has more similar lung function that fit into a certain category based on the closeness of our lung function. And what you see is if you identify as Caucasian, what they used were data obtained from Europe, Israel, Australia, USA, Canada, those who were Mexican American, Brazil, Chile, Mexico, Uruguay, Venezuela, Algeria, and Tunisia. So anybody from those countries or have a background from those countries would be labeled as Caucasian. And then Black, again, is African American. And even for Northeast Asian and Southeast Asian, being Asian, I can tell you it's very difficult to figure out which category you would fall into. Northeast Asian derived data from Korea, and then China north of the Huihe River and Qingling Mountains, where Southeast Asia was Thailand, Taiwan, China, including Hong Kong, south of the Huihe River and Qingling Mountains. So China is represented in both of those categories. And then other was reserved for people who didn't fall into any category, but it was also a average weight of all of the other categories. So an equation based off the entire cohort and thus considered to be race neutral, and the one that we recommend people use today. Taking a deeper dive into the African American data set from the 4 sources. It included data from a study that was published in 1993, where 989 Black children between the ages of 16 to 18 years of age were included. What's interesting about this data is that it was a cohort from the Harvard Six Cities study, which is a major epidemiological study that looked at the impact of air pollution on mortality and found that there was a correlation between worse air pollution and mortality. It excluded smokers and asthma, thus quote unquote healthy lung function. And the largest group of Black children, about 400 from this study that were included in the GLI, were from one of the 6 cities, which is Steubenville, Ohio. And what you see here on this right chart is that Steubenville actually had one of the highest level of air pollution amongst all of the 6 cities. The second study that they derived the sample from was the Hankinson's, which was the old equations that most US labs were using, that included 2,508 Black Americans between the ages of 8 to 80. And this was derived from the NHANES 3 National Health and Nutrition Exam Survey that's done by the federal government. And what they did was derive from that survey, excluding those who were smokers, who had asthma, chronic bronchitis, emphysema, lung cancer, who reported wheezing, persistent cough, phlegm, moderate shortness of breath, and considered those individuals to be healthy. And what's key here is that there's no socioeconomic markers related to any of these individuals accounted for. And what's really interesting is if you go deeper in, that 233 were between the ages of 51 to 80, and that's who we've derived these reference equations from. And in fact, if you look at Black men between the ages of 51 to 80, there are only 72 individuals represented in that age group. They also mentioned 2 other studies with no specifics, and NHANES 4, which was never published, and personal communication. But if you add up these numbers, it's pretty close to the 3,500 that are represented in the GLI cohort for African American or Black. So we do know the factors that affect lung function go beyond those things that I mentioned that determine whether a patient has healthy lungs or not, and that include childhood respiratory infections, nutrition, air pollution, particulate matter, occupational exposure, just to name a few. And there have been studies showing that socioeconomic background is associated with lung function independent of what we ascribe as race. And to give you a solid example of what the implications of that are, if I have somebody, again, I'm correcting for age, sex, and height, a 60-year-old man who is 5'10", using GLI equations, and this individual identifies as Caucasian, Black, or other mix, or the reference equations that I'm using. The absolute value, this is the forced expiratory volume in the first second, a common measurement that we have in spirometry. And let's say this individual actually produces 2.3 liters of volume within the first second. Using the predicted value based on race, the percent predicted if this person identified as Caucasian would be 64%. And if they identified as Black, it would be 75%. So think about that in the context of somebody who has asthma or has COPD. Basically, you're saying for somebody with an absolute value that's identical, if you identify as Black, your lungs are more normal than if you identify as Caucasian. Same for the FVC. If their absolute value is 3.18 liters, you see there that their percent predicted if they identify as Caucasian is 68%. Whereas if they're identified as Black, it's 81%. Again, think about your patients with interstitial lung disease, and these are just one example of many. For example, if they have idiopathic pulmonary fibrosis and you're considering therapy for them and looking at FVC as one of the factors, you have somebody for the same absolute value being considered normal, whereas one individual is now considered to be abnormal. And at the VA, we're currently looking at this in the context of Comp and Pen, which is compensation and pension or disability ratings. And based on these values, if we look at somebody who is trying to get compensation and pension for laryngeal stenosis, if they identify as Caucasian, they would be 30% service connected, which is associated with dollar amounts. Whereas if they identify as Black, they would only qualify as being 10% service connected. And if they have interstitial lung disease, it would be 30% if they're Caucasian, whereas you would get 0% service connection if you were Black. However, if we use the race neutral equation of other mix, you see that everyone would be 30% service connected. So what are the benefits? I think I've expressed some of the benefits, but just to really point out that we, by going race neutral, will equally diagnose severity of lung disease with obstruction and or restriction. Patients will equally meet criteria for certain therapy. And also, I think very important for us moving forward is clinical trials and involving people based on what their true lung function is. Equally qualify for benefits that require lower percent predicted values, comp and pen disability. And obviously there's a long list of this, but I'm limited to 15 minutes, so I'm keeping this relatively short. I didn't lead with this, but I think this is so important in the context of how we think about race in clinical algorithms today, especially in PFTs. If anybody would like to take a deeper dive into this, I recommend this book, Breathing Race into the Machine by Lundy Braun, who really details the history of spirometry in the past and how we practice with our equations today. But the history of race and lung function, historically, truths about lungs of Black people were used to justify slavery and deny disability claims. Samuel Cartwright, who was a Southern physician and plantation owner, arbitrarily denoted a 20% racial difference in forced vital capacity, stating forced labor was a cure for the lack of vitality due to weaker lungs in slaves. And to be honest, if you look back, just in the past few decades, we were still, not we, but many of the labs were still using an arbitrary decrease in the lung volume based on this unscientific proportional decrease for those who are identifying as Black versus Caucasian. And I'm hoping most labs, if not all the labs, have now moved forward to removing that unscientific racial proportional difference in volume. Benjamin Gold, who was an astronomer, measured lung function of Union soldiers and found that Black soldiers had lower lung function, again, not accounting for the horrible working and living conditions of Black soldiers at that time. And even Prudential Life Insurance adopted that data to determine that lower lung function as normal for Blacks, oftentimes using that to deny disability claims. Going back to coal miners in Britain, gold miners, and silicosis in South Africa, they found many similar findings when they tested people who are working in these industries, but they also did not again account for the fact that Black individuals during those times within those industries were assigned the worst of the worst jobs with the most exposure. And as technology improved, and I'm guilty of this, these equations were built into the machines where we think less about the history and the inequities that resulted from prior biases. And I always ask people, do you know which reference equations are being used in your spirometries and the results that you're looking at? And is there race within the clinical algorithm and the reference equations? And if so, if you consider what the impact of that is on your patients based on some of the slides that I presented. So my last slide is really, we need to stop using race-based reference equations for lung function testing. Our National Society, ATS, came out with a statement recently last year stating such that we should be removing race. We should also be looking at the impact holistically and studying that, but the first step is to remove race. When using GLI, to make sure that we don't ask race, that we just use the other, there is another equation called GLI global, where the GLI investigators went back and looked at the entire cohort, and without using weighted averages of instead of using averages of the weighted averages, they just looked at the entirety of the cohort and developed separate equations. I can tell you that the expected does not change. It's the same as other, although the confidence interval may be a little bit wider. And if you do think about making these changes, there are some considerations. And one of them I think is really important is that you want to make a note within your PFT interpretation that this change has been made. And it's not as important, I think, for individuals that are getting their first test. But if you are seeing a patient who's had PFTs or spirometry before, and you're using spirometries to follow that patient, it's important to note that change, to know that your percent predictors will change, and why we should be really looking at absolute values within individuals to monitor change over time. So I will stop there, and again, thank you, and I'll take any questions.
Thank you very much, Dr. Ju. That's absolutely fascinating. And I know you only had so much time, and I'm sure you could talk about this at much greater length. But I think maybe I'll start by just asking a question about the use of pulmonary function tests in the first place, which is that, my understanding is that spirometry is a comparative test, that really what you're trying to figure out is how one person's lung function relates to the typical lung function of other people. And I wonder if you could talk just a little bit about the uses of pulmonary function testing, and specifically like how important that is to test one person's lung function comparatively against other people, and why we're even having this conversation around the way that that sort of cohort was constructed that we're comparing people against.
Sure. I mean, I think with any test, we want to compare people to what we assume should be their normal. I'll talk about spirometry in the context of asthma and COPD. First of all, we don't do it enough. And we certainly don't do it enough to diagnose. So anybody who has a diagnosis of asthma or COPD should have a spirometry that's consistent with that diagnosis. If you don't have that, then you're at risk for having diagnostic error. So I throw that out there. That's actually based a lot on the research that we do, that a lot of patients are misdiagnosed because they don't have spirometry. As far as the ratios, let's stick to obstructive lung disease. Whether you're using race-based equations or not, turns out the ratio doesn't really change much because the FEV1 and the FVC changes. And so the ratio that we use to determine obstruction, again, whether it's gold or whether it's lower limit of normal, there's some nuances to that. That won't necessarily change, but you're based on these predicted using race versus not, you're actually changing the severity or how you would rate their severity of disease. And that's where I think it's really important. And this is really not a test if you're using it more than once in an individual to compare to other individuals, but that individual themselves, which is why I think that absolute value is really important. And then also why that percent predicted and their predicted is so important, because if we don't use the right expected norm for that individual, we misclassify disease. And that's kind of the point of why we need to move away from race.
Thank you very much. I also wonder, like in certain contexts, because it had been brought up by one of the folks who was introducing themselves before, like how spirometry can relate to other lung function tests, potentially like FeNO, that can um, help give more information on an individualized basis about a person's lung function. And I wonder if you could talk a little bit about just how you use spirometry in a clinical sense, and how you bring in other tools to sort of like, I don't know, create a more nuanced picture of lung function.
Well, I think that's really important that spirometry does not in itself diagnose disease, right? Spirometry is just like any other test. We have a clinical suspicion of disease and we have a pre-test probability of disease, and then we use spirometry to support that diagnosis. So certainly somebody who has a fixed obstruction, you can't just say that's COPD. That could certainly be bronchiectasis, that could certainly be asthma. So I think all of those other tests are extremely important, whether it's FeNO, whether it's repeated spirometry, whether it's chest X-ray, looking for emphysema on a CT scan. I think those are all adjunctive things that we look at in addition to the spirometry. But looking at this in the context of spirometry and diagnosis, the first diagnostic test when you have a clinical suspicion, I'm still going to say, is spirometry. All of those other things that we talked about are adjunctive to support. Or if you have a patient, maybe you're thinking, I'm not so sure, it's kind of on the cutoff. And again, there's always gray. It's never black or white. They may be slightly below that expected and don't really fit that diagnosis. And you can maybe say it's not asthma, or slightly, above the expected and have clear symptoms of asthma. And you say, well, for this individual, I think it's close enough. I think it's going to be asthma. So we do have to make those nuanced decisions, and that's what we're trained to do as physicians and nurse practitioners and people who diagnose disease. So it is important to have all those other factors. I think it's supportive and can also, especially for people who are on the borderline of a spirometry, but I'm still going to purport that it's the go-to test, whether it's asthma, looking for that variability and that obstruction, and definitely for COPD, where you have to have that fixed post-bronchodilator obstruction, which defines the disease once you suspect it.
Thank you. And if anyone else has any other questions, we've got about 1 minute left, and we could probably take another question. And otherwise, if not, then,
Hello.
I see. Hi, Mimi.
Hi,
Yeah,
Matt.
I'll pass it over to you.
Okay, I've been trying to think of how to phrase this. First of all, Dr. Drew, thank you so much. I think I speak for all of the collective here that that was an amazing presentation, and we wish that you had had more than just, 20 minutes or so. So maybe I'll reach out to you as well later. But so we do teach about spirometry here at the Lung Association, and one thing that I'm very passionate about is thinking through, the social determinants of health and other things and factors that might be playing a role in this, including race-based medicines like history of racism and structural ways of, like you mentioned, right, kind of purposefully using it against people of color, specifically our Black siblings. So with all of that in mind, something that I have come across certain, people or educators on this topic has been, well, what about research that says or shows that certain people's like lung cavities or sizes differ from like Caucasian to Black to Asian? And I tend to kind of answer with the historical look at, well, how are those tests and researchers, how do they test, right? And what biases that they bring into even just the research. But I'm wondering how you would respond to potential pushback if we take this back to community or we take this back to other educators on spirometry, or if you have any personal examples of that.
Sure. What I always say is I can have a study support any random idea I have, probably. Is it scientifically based, right? It's really what it comes down to. Certainly, I can sample individuals with a hypothesis, and depending on the size of the sample or the region that it's collected from, may be consistent with your hypothesis, which may, again, not align with the scientific basis that race is not associated with biology. I can tell you that in pulmonary, I still remember when I was a fellow, discussions about, well, if you're Black, then your torso to leg ratio is, higher there, or I'm sorry, smaller, therefore Black lungs are smaller. There's no scientific basis for that. So I think what I would say is, let's start with the science, which is that race is not biology. The other thing that I would say is, what is race? And push back on that. So, for example, if you are 1/3 of a background that's from sub-Saharan Africa, and you identify as Black, but you are 66.6% of European descent, where does that individual fall? Socially, that person experiences life as being Black, but biologically, where does that individual fall? And that's where it goes back again to the science. So I always go back to race as a social construct. Every cohort, depending on how small, where the region they were, may support a different, may have a different result, but the science is the science when it comes to biology and race being a social construct.
Thank you.
Wonderful. And okay, with that, I think it's time to wrap up. So thank you again, Dr. Ju, for your presentation today. Really fantastic. And we do have a survey that we shared in the chat. We'll also share it by email for those who have already left. If you could just take about 5 minutes to give us your impressions and make sure that we can continue to bring you material that's relevant to what you do. And otherwise, we have some upcoming events, which we're showing here, and we hope to see you there. And thank you again for joining us.
Thank you.